All right, good morning, everybody. Welcome to our ocular rounds, November 27th, 2024. I'm Dr. Jamie Miller, and I'm going to get us started. When the slide advances, there we go. All right. First up, these are the left and right eyes from a 12-year-old Pomeranian that's male neutered. We ended up getting both of these eyes. And so this patient has a history of having cataracts in both eyes for about a year per the owner. And that the patient's left eye has been bulging for the last 4 months. And so on examination clinically, the dog was diagnosed with lens subluxation. So we can see that our lens is way out of position here. And it's very opaque and probably a little like white foci here. And so it has a very advanced cataract as well. The dog was diagnosed with secondary glaucoma and retinal degeneration in both eyes as well. And so after discussion, they elected to enucleate both eyes. Otherwise, the dog has a history of an elevated BUN and triglycerides. And then when we received the eyes, they looked pretty similar on gross examination. I don't have any pictures of the hemisected globes, but they were both ophthalmic with a hypermature cataract. The lenses were either subluxated or posteriorly luxated, and the vitreous was thin. And so both eyes were very similar histologically as well. There wasn't much to see in the subgross, so I'm going to jump right into our histology. And I'm going to start with the right eye because this was just one of the differences between the two eyes. Where here in the cornea, on the periphery here, our corneal epithelium is hyperplastic. Comes here, and then it starts to separate from the basement membrane here, and the epithelium that's separated has a loss of polarity and these little swirls or eddies formation, and so this is consistent with an indolent ulcer. And then I'm going to switch over to the left eye because it's got a good representation of everything else that I want to show. I'm going to head back up towards the front here. So there's no ulceration in this eye, but both eyes did have a very mild keratitis and vascularization of the corneal stroma, mostly peripherally. And as we look back, stay at this magnification here. Here's our iris leaflet. We do have a little bit of lymphoplasmacytic anterior uveitis. And on the front of the iris here, we have a preirital fibrovascular membrane or epiphyseal. And that comes around and crosses our iridocorneal angle here and forms a peripheral anterior synechia. And then also it goes around the tip here and curls the pupil margin here back into the rest of the globe. And so it's got some entropy on uvea as well. And then we can confirm our hypermature cataract here. So our lens is backwards in the globe here. This is the anterior lens capsule. It's very thickened as it is normally. And here's a posterior lens capsule that's a little bit thin. So the lens just got a little bit turned around during processing. Sometimes that happens, which is why we like to note the lens position when we cut it grossly. And it's nice to have the clinical impression of the lens position as well. But for cataract formation here, we have posterior migration of the lens epithelium. So there normally shouldn't be any lens epithelium lining our posterior lens capsule. We have liquefaction of our lens fibers, some Morgagnian and bladder cell formation here with the nuclei still present, and some mineralization of the degenerate lens fibers. And then there's also wrinkling to our lens capsule. So all of this confirms our hypermature cataract. And then if we head back towards the retina and our optic nerve. We can see our optic nerve head is very cupped. Getting closer, it's a little bit hypercellular here, so the optic nerve, rest of the optic nerve is sclerotic. And if we look at our retina, we can see that we don't really have any ganglion cells left. Here's maybe one here. And we've got a little bit of variable atrophy of our inner nuclear layer as well. Interestingly, on the left eye only, and wasn't seen on the right, there is a little bit of a vasculopathy here in these central vessels in the retina, where the wall is kind of expanded by this eosinophilic material. So I've seen in a couple blood vessels centrally. So possibly there might be an underlying vasculopathy going on. It is an older patient, maybe a hypertensive vasculopathy. There's another one. There's one more.
Yes.
Yeah, this one right here, you kind of lose, not really sure where the lumen is anymore, so very interesting. And then the other finding here gave us some things to consider is as we go along here, we can watch our outer nuclear layer in our photoreceptors kind of disappear and get atrophied and go away. Here we go, right here. So we also have some segmental outer atrophy of the retina, which could be associated with glaucoma, maybe an ischemic event, but we've got both eyes and then both have advanced cataract. And so we started to also think about like primary retinal diseases such as progressive retinal atrophy or sudden acquired retinal degeneration. And so we were curious if potentially this dog had any other signs clinically that would have suggested that it also had a primary retinal disease, if maybe there was any blindness that preceded the cataract formation, or if the dog had any abnormal electroretinogram, which would be no.
That could be ischemic from hypertensive vasculopathy.
Yes.
Vasculopathy with that.
Mm-hmm. Yeah. No, I think the choroid wasn't too bad. There have been a few forms of progressive retinal atrophy reported in Pomeranians that have like a variable onset of the age for blindness. Retinal vasculopathy in the left eye here, again, might be systemic hypertension, which has been reported in cases of SARDS, the sudden acquired retinal degeneration. So we were curious if this patient did have any evidence of hypertension. And also if it had any underlying endocrinopathies, because that could be something associated with SARDS as well. But either way, there's no evidence of an infectious etiology and no evidence of neoplasia. Just a nice variety of lesions. So again, both eyes were fairly similar with the hypermature cataracts and secondary lens luxation. The fibrovascular membrane formation in the peripheral anterior synechia. So the lens luxation and those, the synechia and stuff, probably leading to secondary glaucoma. And then those segmental outer retinal atrophy, it was a little bit worse on the left, which is why I showed that for rounds here. With a couple differentials of why there could have been outer atrophy as well. And then just caution to the clinician, and just in case with the vasculopathy, maybe just make sure the dog doesn't have hypertension, and then a little indolent ulcer on the right eye. All right, so that was my first case. All right, this next case is from a 6-year-old male neutered boxer mix. This is the left eye that comes with a history of ophthalmos, episcleral injection, diffuse severe corneal edema, and a fibrohemorrhagic clot in the anterior chamber. They said yes to glaucoma with an IOP of 54. Been going on about a month. The other eye is, they say normal, but they do note that there's pigmented asteroid hyalosis in it. And so that is the information I'm going to share. I do have a gross picture of this one. So this is our hemisection view of the globe. Our cornea here is at the top. And we can see that where our iris is in our anterior uvea is there's a lot of white material and tissue and shmoo stuff here. So, and it kind of thickens the sclera here and kind of undermines our choroid here as well. The lens was a little bit cloudy. Here's our retina was detached diffusely and a little bit torn. So we can see some of the torn edges here that are being pulled away. And we can't really tell what the optic nerve is doing from the distortion from the detached retina. So let's take a look here. All right, this one I am going to do a subgross view. All right, so globe a little bit boophthalmic, didn't quite fit on the side, but we've got most of what we need to see. So our cornea is up top here. It's a little bit hypercellular here in the middle. Here are our iris leaflets and ciliary body here. We can see our pigmented epithelium from our anterior uvea, and we can see that there's a lot of pink material and debris here, and that continues on back this way. Here's our detached retina. Then we get a little bit of hypercellularity back here in the choroid and our optic nerve with a little bit of scratch artifact on our lens cap, our lens capsule, geez, our slide cover. All right, so. All right. All right, so starting at the top here, well, I guess this is the bottom of our cornea. The epithelium is a little bit hyperplastic. There's a little bit of edema. All of this is fibroplasia and some blood vessels and some neutrophils that span the stroma here. And then what we have here is a bunch of eosinophilic fibrillar material in the anterior chamber, and then it just sort of effaces our anterior uvea. And so this is all necrosis of our iris and ciliary body. And it's very, very vast over here. Just a quick look at it. Not much to see because there's not a whole lot of cellular detail. So we can see our leftover pigment from our anterior uvea, and then just necrosis of the cells that are here. All right. And then as we head back towards the back of the eye, we do see a little bit of cellularity here that we can maybe pick up on the periphery here in the sclera. And we start to see a population of spindle cells with very big nuclei. And if we keep going, they're all back here in the sclera. Again, lots of necrosis here extending into our choroid. And then we're going to go over here where they're a little bit more viable and a little bit easier to read. And so here in our choroid, got streams of neoplastic spindle cells. That have a very scant amount of eosinophilic cytoplasm. Their nuclei are kind of round oval. They have very prominent 1 to 3 nucleoli. And mitotic figures were recognizable throughout this population. And I think if I keep going, and then here we have one of our vessels in the choroid here, and we can see our neoplastic cells are probably in our vessels here. So we have vascular invasion, probably not too surprising for a method for it getting to the eye. So this is consistent with a metastatic sarcoma. of some variety. Here is our detached retina. A little bit of lymphocytes, plasma cells, maybe a few neutrophils in here. But we also, let's see if I can find them. We can also see our neoplastic cells are lining the retina as well. So we've got a little bit of extension here into the vitreous. Our lens was also pretty hypermature, similar to the first case, so I won't spend too much time on it. And then just more of our neoplastic cells extending into the vitreous and then all the necrosis. And that's who is in our sclera as well. So more of these neoplastic cells.
So dare I bring up the point in Bill's book about how sarcomas are more likely to met to the choroid and carcinomas more likely to met to the anterior, or I can't remember if it's the anterior chamber or the uvea.
How dare you?
Just want to see if folks still like somewhat agree, mostly agree, completely disagree.
Can you repeat that, Jamie?
Yeah, so the question was in Dr. DeBilzig's ocular pathology book. There's a mention that maybe sarcomas are more likely to metastasize to the choroid or posterior segment of the eye, and carcinomas maybe more the anterior segment iris stuff.
I don't know if I'm right, but
I'm asking for opinions, not facts.
there you go. So I can give you opinions and not facts. Presumably that is based on like the data set of Coplow's cases. So like how many cases metastasized where in the database. And I think that there are probably some things that can impact that and introduce bias. So for example, like there's the notion that hemangiosarcoma most commonly met to the ciliary body, and that's the one I talk about the most with visitors, for example, of like maybe there could be a bias there towards like those are the cases that get recognized as ocular disease more and taken to an ophthalmologist and nucleated, and is that why we see them more often in the ciliary body versus the choroid? Or is it actually that they tend to met there more often? I don't think we know that. So I mean, but that said, like if you look at the data set and that's what we come up with, then that's at least some sort of a guideline that's worth paying attention to.
Yeah, if you know cells, go ahead.
And my bias, I don't know, so I don't know in that book whether he was referring to Coplow cases or not. But in general pathology books, they always say things metastasize to the choroid more frequently than anywhere else in the eye. And my opinion is that we have a biased outlook on where things metastasize to the eyes, because that's all we look at. Whereas on a necropsy floor, they're looking at the entire animal and they take the eye occasionally and they find that it's in the choroid. And I think that might overall be true, that they metastasize to the choroid. I don't know about sarcoma versus carcinoma, but they metastasize to the choroid more frequently. But because that doesn't necessarily always lead to obvious ocular disease,
Yeah.
the eye is not always enucleated. And also, so in human med, when things metastasize to the choroid, it affects the vision because it affects the retina. And a human is going to say, hey, there's something wrong with my vision and go see a doctor. But a dog or a cat is not going to do that necessarily. It's not going to be noticed. And so they might not be evaluated for decreased vision or whatever because there's metastatic disease to the choroid. So that's my bias. I don't know if we'll ever get to the bottom of it.
I agree, and sometimes it's hard because of that bias. With animals, we tend to see a more advanced progression of the metastatic disease because they often get nucleated when there's glaucoma. So it's not uncommon for us to see something like this where we see both patterns, both anterior uveal metastasis with growth on the ocular surfaces plus intravascular and intravascular component, and it's hard to tell which one came first at this stage. But I think it's important to think about what would lead a pathologist to think that a neoplasm is metastasis to the eye. So I think those two components, carpeting of the ocular surfaces by neoplastic cells without necessarily forming a well-defined mass, and an intravascular component along with that. The intravascular component has to be taken with a grain of salt because you never know if they're coming or going, right? You can have a big mass and the cells get access to the vessels, and we'll certainly see that inside vessels, but you don't know. But this multifocal nature of the neoplasm, ocular surface carpeting plus or minus a mass with a vascular component, are things that should be taken into account. And you'll be impressed by how often we don't get a history of a primary mass elsewhere until we get the eye. And then, plus or minus, with or without a systemic workup, very often there is like just basic ultrasound and thoracic radiographs with nothing obvious. But then we got that pattern that's obviously metastatic, and they'll go back and, we try to guide a little bit where they might find the primary mass. For example, if you see a hemangiosarcoma, you know where you're trying to say, like, go to the base of the heart, go to the skin, the spleen, or if you have a random non-discrete carcinoma, we know that the more common metastatic carcinomas to the eye are from the respiratory tract, so either nasal or pulmonary. So we will try to say, hey, go check that. Or if it's a metastatic melanoma, which brings its own challenges to diagnose as metastatic, we'll tell them, check the mouth, count the toes, check the skin, right? But we don't often get a clear indication where the primary mass is.
Well, I do have more information for you
Mhm.
for this case. After that lovely discussion of everything. No, that's perfect. That's great. Part of the reason to maybe hold back some key information. So this dog was actually diagnosed with a fibroblastic osteosarcoma of the left mandible. And it had a left hemimandible, oh my goodness, had part of his mandible removed in surgery in May of this year, and it was incompletely excised. It did go through some carboplatin chemotherapy from June to August, and then they noted local recurrence with bony lysis on the CT scan in mid October. Did get some palliative RT radiation therapy from the 22nd of October, or for 2 days they did note that there was no evidence of pulmonary metastasis on CT or thoracic radiograph in May, July, and October. But then the eye kind of broke with its severe uveitis and early glaucoma, and so they took it, and that's what we have here. So yeah,
Was that on follow-up, or did we have that information?
we had that information.
Okay, good.
So it was very lovely to have that. And so there's nothing specific here in the neoplastic cells that would have led me to the differential of a fibroblastic osteosarcoma. But again, it would have, if we didn't have that information, it definitely would have been like, this is metastatic to the eye. You should go find the primary elsewhere, but that they already knew where the primary was and that it had recurred. So again, metastatic sarcoma, as per history, the fibroblastic osteosarcoma with the vascular invasion, and then the other kind of secondary findings in the eye. So
That is also very cool because I think there's a lot to be said for like when metastatic osteosarcomas start to actually produce osteoid and like the different cellular signals they get from different stromas. So.
oh yeah, okay, yeah, that's very interesting. So the comment, if in case it wasn't heard, was the interesting of metastatic osteosarcomas and when they might produce matrix depending on the stroma that they're in and around. So very cool. All right, and I will make way for Dr. Clemens.
Okay. I'm Megan Clemens. I have a pair of cases for you today that kind of go together. So the first case is a 11-year, 5-month-old spayed female mixed breed dog. Let's see. You probably have already spotted the problem on the gross image. However, the history is mass starting from left lateral conjunctiva, eye functional until mass/conjunctival swelling covered the globe. So you can imagine neoplasm does not make a good pair of sunglasses. There's also some other very interesting history in this case, although difficult to be certain about it. There's kind of some vagaries, I guess, to it or difficulties to it. But they describe that the patient was seen at an emergency clinic, so not the clinic that enucleated the eye and sent it to us, for a breathing issue. Thoracic radiographs showed pattern compatible with possible metastatic disease per their reading. The dog was put on prednisone, and our reading of RADs, so that the people who sent this to us, and follow-up RADs did not show any signs of metastatic changes. The dog's breathing was better on the prednisone. Owners felt it increased again when taken off of the prednisone 5 days ago for surgical prep. So a very interesting history there, although difficult because it's kind of a lot of like owner said and word of mouth, but still interesting and worth paying attention to. So this is a periocular / orbital mass. We have this very large tan white structure here, sort of smushing the globe off to one side. The conjunctival surface is probably roughly here or so. So you can see how, like, if you were looking at this eye from the front, you would see this as a subconjunctival mass, kind of nudging the eye to the side. With periocular and orbital masses, it's useful to pay close attention to where the mass is arising from. In general, for diagnosing neoplasia, which this may not be neoplasia at this point on the gross, but I'll spoil you and say it's definitely neoplasia based on histology. If you're thinking about neoplasia, generally it's a good rule of thumb to think about what tissues or cells may actually be at that site normally, to think about what may have arisen in that site. So for example, for periocular tumors, it's good to know kind of where it is. So for example, if you end up with an epithelial neoplasm, you can wonder about whether it arose from the accessory lacrimal if it's more dorsal, or third eyelid gland if it's more ventromedial or something like that. But this one is just lateral, and none of that information may be super relevant to this case. Just something worth pointing out as a pointer. All right, so let's take a look. I'll start with the large slide just to give you an overview, but we'll switch pretty quickly. See if I can make this work. Wait, isn't it 2x? Oh, it is not on 2x. I thought it was somehow. There we go. So here's our eye looking kind of much like it was on our gross view. Here's the cornea, here's the lens and the iris, and then the giant mass smushing it off to one side. You can see a piece of the third eyelid kind of coming in at a weird angle up here. So this is the third eyelid cartilage and the gland around it. And it's not really involved in this. And here's our mass. So we've got sclera with our scleral venous plexus here, these holes. And you've got your peripheral cornea starting here. So it's mostly just sort of next to the globe in the periocular tissue. And here it is. Pretty big. Okay, we're going to try and put cornea to the left, be consistent. All right. Let's see. Let's reorient here just to make sure that I did what I said I would, which I don't know if I did. Dang it, where are we? Here we are. Okay. So here's our cornea facing to the left now, and here's our mass. And you can see that with this very large tumor, which was left in situ on the globe and sectioned as is, the middle part of the tumor is kind of poorly fixed and doesn't look great. You can't really see a lot of cell detail. So another neat tip is if you have a large mass, it's often good to take a smaller slice of that mass from the edges of it more, which is good both for cell detail and if you need a smaller slide for running IHC later, which we did do in this case. But I'm going to start with the big mass just to show you the extent of it. You can see at the edges here, it's showing its invasive behavior, spreading into the orbital fat and kind of individualizing these little adipocytes. And over here, you can see it spreading into an extraocular muscle, invading between the individual myocytes. So it's got some fairly invasive behavior. I'm going to drop in here where it's more better fixed at the edges. And the neoplastic cells are admixed with a good number of inflammatory cells, so we're going to move slightly over so we see mostly neoplastic cells. And then stop and then talk instead of roaming around. We have round cells. So each of these cells is fairly round. You can see that sometimes the shape of the cells is not quite round. They can sometimes sort of mold against one another and get like funny looking shapes. But keep in mind that there can be that kind of molding effect with really big neoplastic cells that can kind of change shape if they're squished against one another. But mostly they're round, and you can see very distinct cell borders. Oftentimes there's even this sort of artifactual clear space as the cells kind of shrink during fixation. The kind of fun thing that we say in Coplow is pretend like if you're playing a game of Operation, if you could pick a single cell out with tweezers and not disturb its neighbors, that kind of tells you that it has really distinct cell borders, and you can think of it as like a round cell tumor, probably. And then also these cells tend to have a fairly high nuclear to cytoplasmic ratio. They tend to have kind of a thin or small rim of cytoplasm and a relatively large nucleus. They've got pretty coarsely clumped chromatin. They've got one or more distinct nucleoli. This one's got two. And probably not obvious in this field maybe, but there's a fair number of mitotic figures. It's a pretty active neoplasm, I can tell you. I got 123 in 10 high power fields. So yeah, pretty mitotically active population. This one, I don't have much else to say about it. Called it a round cell neoplasm, and my top differential for something like this is a lymphoma. The neoplastic nuclei, you can kind of measure them with an erythrocyte as a ruler, and you can categorize them as small, intermediate, or large. At least to my eye, the nuclei were roughly 1.5 erythrocyte widths in diameter most commonly, so I called it intermediate cell. We didn't end up doing IHC on this one because they didn't take it up on that yet, but something like that, top differential lymphoma. So that's the first case. If there aren't any questions or comments, we'll compare it to the next case. Yeah, of course.
Did the prednisone have certain
Oh.
prednisone that changed the results of the program?
So the question was, could the prednisone have changed the results of the chest radiographs? That's a good point. I forgot to go back to that interesting history. I just said, oh, that's interesting, and then didn't revisit that. So yeah, the question is, could this be a lymphoma that's also involving other sites in the body, maybe somewhere in the chest, and could the prednisone have affected it? That is part of why that history is interesting. Certainly lymphoma can respond to steroids, and that can change what the neoplastic populations look like, and maybe could have changed the imaging results. It's difficult for us to be sure because there are a lot of like parts of that history that's kind of like owner said and secondhand information, but it's definitely interesting in context of a differential diagnosis of lymphoma. And that is a good point and a good catch. And I should have gone back to talk about that. The other thing to say is that with periocular orbital lymphoma, it can be primary around the eye and may not necessarily have spread to other sites in the body yet. It can be a manifestation of a lymphoma that's already become multicentric or metastatic. So basically, we will typically suggest that the patient be staged, and then it'll be up to the clinical team to determine whether there is involvement of sites outside of the eye, and how extensive that involvement is. Basically, we can't predict that based on the histology of the eye alone, which is also something that I meant to bring up and almost forgot about. Thank you. All right. Any other questions or comments in this case? Okay, in that case, we'll do the next case. All right. So this next one is a 3-year, 11-month-old dog, a much younger dog. We have a spayed female Labrador Retriever mix. And you can see that the gross image is actually fairly similar to the last one. There is this large, relatively homogeneous tan white mass, sort of in the periocular or orbital tissue. And that's part of the reason why I wanted to compare. They have a very similar gross appearance. And there's definitely a lot of overlap between gross appearances of different differentials. This patient's history was exenteration performed due to a soft, fixed dorsomedial orbital mass involving the medial canthus and also the third eyelid, resulting in exophthalmos/temporal strabismus. So it was shoving the eye over temporally. Preoperative CT scan preliminary results reveal that the mass was occupying the entire orbit and beginning to invade adjacent nasal bone, so a pretty invasive mass. Biopsy performed elsewhere, but results are unavailable. So we don't have that. History of mature cataract. There were normal thoracic radiographs and some mild kind of abnormalities on blood work, but nothing too obvious as to what's going on, and no significant systemic concerns. So they do say that the mass is mostly dorsomedial, but it's pretty extensive and large to involve the third eyelid, which is more ventromedial. And you can actually see that in this gross image. So here's the third eyelid here, actually. You can see this is the leading edge of the third eyelid. The cartilage is kind of in section here as this sort of white band. And then kind of this tan tissue around that is most likely third eyelid gland. And then there's this mass that's right next to it and kind of squishing right up into it. And it's pretty big. And you can see how this would be smushing the poor eye to one side. There is a cataract, but we're going to focus on the mass again. Not that mass. We looked at that one already. All right, we'll start with the big slide again. Thank you. See, here's our little smushed eye down here, but we're going to focus on the mass. So once again, you can see this third eyelid, the leading edge curling off to the side here. You can see the cartilage in section here is this sort of glassy, pale basophilic thing. And then all this stuff around is going to be the gland, and we'll look at that closer in a hot second. And then here's the neoplasm, which is pretty big. It's actually fairly well demarcated along some of its edges, but we'll see that it does have some infiltrative behavior in a hot second as well. And it's pretty highly cellular, a very purpley mass. All right, let's see. I'm going to put the cornea to the left. It's my habit to put it to the right, apparently, without even realizing it before. All right. So here again, one more time, is our third eyelid. The tip of it kind of looks like the sorting hat from Harry Potter. Anyway, that wasn't really a scientific observation. So the cartilage again, and then the gland again. And the reason why I keep belaboring the third eyelid's proximity to this mass is because you'd wonder in this case where they said clinically that it was involving the third eyelid, whether this might be a third eyelid gland neoplasm. Gesundheit. However, Gesundheit. Comes in threes, comes in twos.
Prevent third line.
So we still can't necessarily rule out just based on this whether it rose in third eyelid or not, but these glands of these lobules of third eyelid gland are sort of pushed off to the side and being compressed by this mass at this level and not necessarily blending into the mass itself. So right now it actually looks more like the mass arose in some other structure and then shoved the third eyelid off to one side, much like it was doing to the globe. You can see that these glands or lobules of the gland of the third eyelid are fairly atrophied as well. So basically fewer acini, more widely spaced, and often these mostly actatic ducts remaining in between these shrunken lobules. So basically pressure atrophy of the third eyelid gland. Can't necessarily rule out that it's a third eyelid gland origin, but it looks more like it arose next to it and smushed it, is my point. Now, moving on to the actual neoplasm, which is what you were waiting for. I have a habit of ignoring the elephant. All right. So this is actually a fairly pleomorphic tumor. You can kind of see already from this magnification, the same kind of effect that we were talking about earlier with that round cell neoplasm, right? There's kind of this artifactual shrinkage, creating clear space around these cells. If you were playing a game of Operation, you could probably grab one of these without disturbing its neighbors. However, hold that thought. Once again, there's some weird shapes, which you want to be cautious about overinterpreting because some of that might be molding of one cell next to the other. But this neoplasm has a much greater pleomorphism to it than the one that we were just looking at. And some of these cells may actually have spindle to stellate shapes. We'll talk about that more in a second. Let's see. There was like one cell that I thought I might be able to land on, but I'm just deciding that I'm going to try and land on a single cell in all of these cells. maybe just take my word for it. I mean, as we're walking along, you can probably see how pleomorphic kind of there's a significant degree of anisokaryosis, for example, like these nuclei are pretty variable in size and shape. I can't find the one karyomegalic cell that I was looking for, and I'm not going to keep looking for it, but
Oh, come on.
I'm being rooted on. Maybe like a couple more fields. I don't know. So, maybe not. I blame the fact that I flipped the slide from the way I usually have it. That's totally why. Totally.
There it is.
Yeah, I mean, there's some good ones still, regardless. Like this one's pretty big.
Galactica,
This one's
yep.
pretty big. Maybe has multiple nuclei on this one. So showing off the pleomorphism. Again, you're probably picking up on a bunch of mitotic figures as we go, which if I pick the right one, let's see. This one had 91 mitotic figures in 10 high magnification fields, so also a very high mitotic rate. It kind of sometimes has the look of a round cell neoplasm, but has much more pleomorphism to it than the one we were just looking at. And maybe some differences in the shape that isn't necessarily always round. And then in particular, if you look at these additional sections here, apart from the large ones, once again, you're seeing that invasive behavior where it's individualizing adipocytes, so it's invading that orbital fat pretty badly. You can see it over here too, very pretty. And some of this is probably reactive cells around the neoplastic cells, which is difficult because some of these may be neoplastic cells and some of these may be reactive. But in these sections, a lot of these cells are showing off a much more spindle morphology. And some of them may be neoplastic cells, which is suspicious again. And then again, you can see these more round ones or round looking ones here. So someone, and that someone may be me, originally suggested that we pursue lymphoma as a differential and kind of regretted it, but it was still good to have the IHC that we had. We ended up doing CD3 and CD20 first. So CD3 is a marker of T lymphocytes, CD20 is a marker of B lymphocytes, generally speaking. And both of those were negative. I can show you that briefly. Wait, what? No? Oh, someone's saying no, we don't have time. So I'm not going to show you that. They're negative for CD3 and CD20. So, you know, if you're watching this at home, you can pause it. Think of a young dog with a rapidly growing tumor that is highly invasive, that has somewhat of a round cell, maybe somewhat of a spindle cell morphology, and is CD3 and CD20 negative. If you think about all those features, you may have some differentials come to mind. And I'm not going to pause now because we don't have time. And I'm going to throw on this IHC, which is a Desmond. And the positivity is quite patchy. The positive result is brown here. There's a brown chromogen. But so not all the neoplastic cells are picking this up. However, some of these cells are clearly showing themselves to be spindle to stellate, and I would argue that a lot of them are showing themselves to be clearly neoplastic and positive. Let's zoom in. So despite the kind of patchy results, basically all those features that I just mentioned, coupled with patchy Desmond positivity in a young dog, rapidly growing invasive tumor, we would have rhabdomyosarcoma, the highest on our list. So that is the most likely diagnosis for this case. The diagnosis of rhabdomyosarcoma in a young dog is not a great one. It's likely to have very locally aggressive behavior. And has a not great prognosis, unfortunately. So just comparing between these two kind of round cell options in the orbits and their gross and histologic appearances. All right. Yeah, I know it's giant. I don't know.
It's yelling at us.
It's yelling at us. I don't know. I made this one rather large.
And when it came out, I'm like, wait a minute, what did I do?
Yeah, that's right. See, we don't always diagnose this one. It's not a good diagnosis, but it's
I want to change it apart because I thought expression of your feelings, I guess, but it's
yeah, that's right. It's an emotional catharsis on this case. All right, that's it for me. I'll move.
All right, we have our last two cases. My name is Dr. Brown. Kelsey Brown. You want my full name? So our first case is going to be glow from a cat. This is a 1-year-old male castrated British short hair. And it presented for being non-visual. When it was referred to the ophthalmologist, they noted ophthalmos, 1+ aqueous flare and hyphema, and they weren't able to perform a fundic exam due to the hyphema. They also noted that in the remaining eye, there was keratitis, trace aqueous flare, and then possible vitreal or retinal hemorrhage, but they were only able to get a pretty limited view of the back of the eye. Grossly, we did also corroborate that the eye was ophthalmic. Grab my mouse. We also know the cornea was a little bit cloudy. We can kind of see some vessels extending from the periphery through the cornea. We also noted that the lens was cloudy, so probably cataractus, and also had this somewhat atypical, almost comma shape to it. And then in the back of the eye within our vitreous, there is some hemorrhage, and then there's many opaque kind of strands that are spanning the vitreous here. So maybe connecting to what's probably retina, all the way out to the lens here. All right. Now we'll move to the histology.
How old was the cat again?
1-year-old. Go. And I'm also going to orient this globe correctly. Yeah. So we have the cornea to the left of the slide, and then as we move right, this is where we get into the posterior segment. So just on kind of low power view, there are some corneal changes. So we do have some corneal vascularization. We can see some pretty well-defined vessels in the stroma. It's a little bit hard to make out the epithelium. So as we go to the periphery, you can see we have our conjunctival epithelium and our corneal epithelium. Even from low power view, it's pretty thin, so we have an attenuation of the epithelium. And as we move more axially, we lose that epithelium, so we do have an ulcer. Actually, we'll take it to her this way. As we move back to look at the iris and iridocorneal angle, there are some changes here as well. So what should be our iridocorneal angle is instead filled or replaced with this kind of loose tissue that we can look at a little bit more closely. There isn't really a well-defined ciliary cleft. And there is a little bit of busyness in the iris stroma, which just turns out to be inflammatory cells, which again, we can look at a little more closely. So there is a little bit of a uveitis. Moving back to our lens, we can kind of see the correlate to that very atypical shape here. So there is cataractus degeneration in this lens. So all of this is liquefied lens fibers. Kind of looking to the left here, we can see this is the anterior lens capsule. As we follow it, perhaps we can't really make it out the posterior aspect. Again, we can look more closely at that. But there is a lens capsule rupture here. Over here, maybe it's a little bit more convincing. Here's where it kind of ends. And then we just have all of this liquefied lens protein kind of exuding out. And then moving to the posterior segment, there's our retina. And it is detached. It gets a little bit folded up and jumbled. But we can look at kind of the layers a little bit more closely when we're able to see them. And there is indeed hemorrhage within the vitreous associated with this retina. We can kind of see these fine little strands that are exuding out from the hemorrhage here. And then our optic nerve is relatively unremarkable, a little bit distorted just because of the retinal detachment. Okay. I don't have too much else to say about our cornea. Ooh, if I can focus the right way. There we go. I don't have too much else to say about our cornea. Just going at slightly higher power view, we can corroborate that it is indeed a little bit attenuated, that epithelium. And there is a bit of a neutrophilic infiltrate in here too, which would make sense. We do have a corneal ulcer as we move axially. Here's that ulcer right there. Moving to our iridocorneal angle. So what should be angle instead is replaced by kind of this loose meshwork of mesenchymal tissue. We can see these kind of small spindle-shaped cells. There are some hemosiderin-related macrophages in here as well. This eye certainly had chronic hemorrhage within it, so that would make sense. They're just kind of getting entrapped within this kind of, I guess, mesh of mesenchymal tissue.
There are some lymphocytes and plasma cells, so lymphoplasmacytic uveitis. Again, this is kind of vaguely where ciliary cleft and trabecular meshwork should be, but we can't really make out anything that's identifiable for those structures. So these changes right here are most suggestive of anterior segment dysgenesis. Another feature that we can see of that is a posterior displacement of the angular aqueous plexus, which as we move more posteriorly, don't know if there's, maybe that's it. Yeah, right there. So that's pretty displaced. It should not be where the ciliary body is. Instead, we would expect it to see more closely at the base of the iris or kind of just past that. Quickly looking at our ruptured lens capsule. So here we have our intact anterior lens capsule. This is a younger cat, so it's a little bit thinner. As we move back, it's getting closer. You can see where it becomes discontinuous, almost like a little spring that broke. And then if we follow that along, it's a pretty extensive discontinuity. So we pick it up somewhere.
Is that capsule?
One day, there it is.
There it is.
So kind of the entire posterior lens capsule is pretty discontinuous. And then if we had any doubts that this was truly a ruptured lens capsule, there are also some macrophages that are kind of interspersed with these liquefied lens fibers, which we don't tend to see with an intact capsule. Right. And then moving back to look at our retina. So this is the area where it's detached. And again, when we kind of get detachment and folding of the retina, it's a little bit hard to kind of look at each layer. Let's see, but there are some changes that we can look at here. So kind of going to the left, we have the inner retina, and as we go right, it's when we get to the outer retinal layers. So our inner retina, really there aren't any ganglion cells to speak of, which this eye was ophthalmic and it was glaucomatous. I forgot if I mentioned that in the history. So certainly we can get loss of the ganglion cell layer because of that. This inner fiber layer is quite busy though, so there's way increased numbers of glial cells with very gliotic retina. Let's see, I probably didn't land on the most distinct area. But there's variably severe outer atrophy as well. So in some areas, there's maybe attenuation or loss of the inner and outer photoreceptor segments. So these kind of like pink frills get a little shorter. And then some areas where we lose the outer and inner nuclear layers, which if this retina has been detached, certainly could be because of that. As we move around, there's also these vacuoles within the outer plexiform layer, which is consistent with retinoschisis, which is not, a terribly specific lesion. And what is more specific though, as we start to kind of fan around this retina, actually I'll go a little closer. Sorry, I'm oscillating between the powers here. It's hard to really make out any vessels within this retina. So we're at the periphery here. And typically we should see some well-defined vessels. You can see them kind of in all layers, but I typically see them most significantly within our inner layers. And as we move centrally, then we can start to pick up some of these small caliber vessels. And again, I'll kind of fan out to the other side here, which is a little less folded. And there really aren't many or any vessels to speak of. All right. So then moving back into kind of this really hemorrhagic area. Along the inner retina, there are these collagenous membranes. A little closer. So we have this really dense collagen, and within those membranes, we have pretty distinct small caliber vessels embedded within it. And kind of emanating from that membrane and from the inner retina, there's a lot of spindle-shaped cells that sometimes make kind of more crude vessels out here. Find this slightly better. Yeah, here's another one. So here's another one of those membranes with pretty distinct vessels that are kind of extending out into the vitreous. So a lot of changes here, but the amalgamation of retinal lesions that we have here and the cat's age is most suggestive of feline neovascular vitreoretinopathy, which I can switch to our diagnoses to show that. So this is a congenital condition that's most commonly going to be diagnosed in younger animals or in younger cats. And the features of it include an avascular retina, often at the periphery of the retina, retinal gliosis, and then epiretinal neovascularization. So those kind of vascularized collagenous membranes we're seeing on the epiretinal surface. Chronic intraocular hemorrhage is also a common sequela to it, and also retinal detachment. So this is a somewhat recent entity that was published in 2019 in Veterinary Pathology. And in a very large subset of cats that were diagnosed with this condition, they also had concurrent anterior segment dysgenesis, as we saw in this case. This case is interesting because it has some other kind of secondary lesions. So we did have the corneal conjunctival epithelial attenuation, as well as ulceration of the cornea, which keratitis was described in these cats that had this, typically just due to ophthalmos and exposure. However, in this case, that attenuation is also suggestive of herpes virus, which this is a young cat, so why couldn't it have concurrent herpes virus in addition to this condition? Anterior uveitis is also quite common in these cats. However, in our case, we also had a lens capsule rupture, which certainly could also contribute to an anterior uveitis. Lens capsule rupture is not part of this syndrome of feline neovascular vitreoretinopathy. So in this case, that rupture could be due to trauma, so like trauma to a blind eye, versus something spontaneous like with an intumescent cataract. In this case, it was kind of hard for us to say exactly what caused that rupture. It's kind of just an interesting associated thing we saw in this case. And then cats with feline neovascular vitreoretinopathy often have congenital glaucoma on account of that anterior segment dysgenesis. With retinal detachment, you can also see fibrovascular membrane formation, and that can also contribute to glaucoma. So these cats typically present under the age of 1 year with glaucoma. And then I had mentioned in the history that they had seen lesions in the contralateral eye, so they described possible vitreal or retinal hemorrhage. This particular syndrome can be unilateral, but then in a subset of cats, they had bilateral disease. So in this case, with the history, there's concern that the other eye might be affected as well. And I think that's all I have to blather on about that. I don't know if anyone else has any questions or concerns. Yeah.
So does the retina have like atrophy of the outer layer?
Mhm.
So is that part of the vitreoretinopathy? Like, because it's not.
Yeah.
listed as a diagnosis,
Mhm.
but there's.
Yeah, no, that's a great question. So the question was, yeah, of course. The question was that I had described that there was outer retinal atrophy, and they were wondering if that was part of this syndrome, in which case it's not terribly specific. This retina was detached, likely chronically. So with chronic retinal detachment, you're losing blood supply to that outer retina, so that can cause atrophy of those outer layers. So likely it's just secondary to the detachment. In this case, it's not necessarily like pathognomonic or a key lesion. That's part of this syndrome.
So it's sort of like under the detachment of that.
Yeah. Yeah, it's not like one of the kind of diagnostic lesions that we see with this syndrome. Good
Yeah,
question.
so mainly, I think it's kind of hard to tell, but one of the things that we believe that causes the disease is a congenital malformation, so a retinal dysplasia of sorts. Potentially, all that retinal gliosis that we see kind of blocks the normal vascular or the normal vascularization of the retina. A lot of the retina in dogs and cats, a lot of the embryologic development of the retina, let's say the final development of the retina happens after these dogs and cats are born, weeks and maybe even months after they're born. So the idea or the hypothesis here is that there is this retinal gliosis, this retinal dysplasia that prevents a normal vascularization to happen, and we end up with a avascular retina, right? And a vascular retina will be an ischemic retina, and that ischemia triggers the vessels to grow into the vitreous as a ischemic response to release of VEGF and things like that. That causes the retinal attachment, and it's just snowballs from there.
Mhm.
Does that make sense? And Elisa is asking, what's the mechanism for the lenticular changes?
So in this case, we aren't quite sure. So lens capsule rupture is not a associated lesion with feline neovascular vitreoretinopathy. In the 2019 paper that goes over that entity, they do describe cataracts as well as lens luxation. Lens luxation could be due to ophthalmos or the cataract, and it's possible that they also get concurrent congenital cataracts.
Mhm.
In our case, yeah, we're a little bit unclear for why the lens capsule ruptured. Certainly, it could just be due to trauma and rupture of that lens. We didn't really see any other lesions that were pathognomonic for blunt trauma, but this eye was likely blind, so it's very, very possible that it traumatized the eye at some point. And certainly, if there was a cataract before that, there could just be spontaneous rupture of a cataractus lens. Again, it's one where we kind of had to hand wave a little bit and couldn't really give a precise mechanism for why it ruptured in this case.
Yeah, makes sense. All right, everyone. Well, thanks for logging in. Thanks for those that came, and happy Thanksgiving. See you guys in a couple
Happy
weeks.
Thanksgiving.
Yeah.
Sure.